So this is who I am, and this is the name of our network, Combine. So I'll be hosting this event today. I'll be introducing the speakers, and I will really encourage everybody to ask questions, raise your hand. Okay, every question is important, and we want to make sure that we have an opportunity to show the public, show our community what we're doing, but also ask questions and ask feedback from the community that will help us, to do better research. So I love these public events. I've done numerous in my life, and I'm always excited about these opportunities to interact with the public. So please feel free to raise your hands, and we'll make this hopefully a very interactive and exciting night for us. And with that, I would like to ask my amazing colleague and psychiatrist-in-chief of St. Joe's, Dr. Maxime Lewis, whom I've known for a long time. Dr. Lewis is a leader here in our community, in our St. Joe's community. And thank you so much, Dr. Lewis, for being here. And Dr. Lewis will give some opening remarks.
Thank you. Thanks, Benicio. You're using a very old photograph, so everyone's probably thinking, who's that up there? But that's me, a few years ago before the pandemic, unfortunately. The grey hair shows. So my name's Dr. Maxime Lewis. I was actually just thinking as you were talking, I've been at St. Joe's for 20 years, so I've known you for a long time. I'm very proud to be working here at St. Joe's, and I'm actually a geriatric psychiatrist. So I look after older adults. So a lot of the people that I see have mood disorders, but lots of other issues as well. So it's not, mood disorders isn't my area of expertise, but I certainly look after people with that with mood disorders. So tonight it gives me really great pleasure to welcome you all to St. Joe's. And to acknowledge the important partnership between CanBind and St. Joseph's Healthcare Hamilton. So the Mental Health and Addictions Programme, at St. Joe's is the second largest mental health programme in the province, and we're just behind CAM8, so a lot of people don't realise how very big we are. And this site where we're at now is actually the home to the majority of our inpatient specialty services, and it also houses some of our outpatient services, including our mood treatment and research unit, and that's where we treat those who have severe mood disorders. But we have outpatient and outreach services across the region. So what you see here is actually just a relatively small part of the work that St. Joe's, the Mental Health and Addiction Programme that St. Joe's does. So I don't think it's news to anyone here that depression is a highly prevalent condition and impacts actually around 1 in 5 of Canadians each year. And we know that early intervention and personalised treatment strategies are essential in achieving better outcomes. So at St. Joe's, our approach has been to care for those with depression, and it involves a lot of different aspects. So we do evidence-based psychotherapy, that's talking therapy, pharmacotherapy, which is medications, like antidepressants, antipsychotic medications, things like that, and neurostimulation, which is ECT, electrical convulsive therapy, and RTMS. So we do a broad range of treatments, and the mission for this program for the hospital is really providing compassionate care with a spirit of discovery. So I think given that spirit of discovery is really exciting, that CanBind has chosen Hamilton as its headquarters. I think that the work that you'll hear about tonight, the work that CanBind is doing is in identifying biomarkers and advancing personalized treatments, has the potential to really transform care for those living with depression. And our collaboration with this network is such a remarkable opportunity, I think, for research, innovation, and knowledge sharing. It's through partnerships like this that will address really all the complex healthcare challenges that we're faced with. And we're extremely proud at St. Joe's to be a key partner in enhancing mental health innovation through this collaboration. So I'll just finish there, and I'll hand it over to my good colleagues, who I'm sure will while away the next few hours and tell you all sorts of exciting things.
Thank you very much, Dr. Lewis, for the kind words. So now we're going to start with the first presentation. So you're going to hear a little bit more about depression treatment first from Dr. Fabiano Gomez. So Dr. Gomez is an assistant professor here in the Department of Psychiatry and Behavioral Neuroscience at McMaster, and also an academic psychiatrist here in our mood disorders program. He has a particular interest in bipolar disorder and also treatment-resistant depression, which means when people that have used like multiple treatments, depression are still not responding to the treatments. That's the profile of individuals that Dr. Gomez treats the most. And his research interests include something called knowledge translation, which is exactly what we're doing here today. So we are bringing some of the research findings and translating that to public education, which is one of the big things that we do in terms of disseminating the work. So sometimes research is isolated in a publication or elsewhere, and the public are not like really aware of what's happening, the exciting things that have been discovered. So knowledge translation is the kern of that, and Dr. Gomez is an expert here in our community. And he is also involved in implementation of evidence-based interventions, and also interested in something called metabolic health and lifestyle in the course of bipolar disorder. We know that metabolic health, like our blood pressure, triglycerides, and things like that, can be associated with depression in bipolar disorder, and also some treatments can interfere with that. So that's another area that Dr. Gomez is interested in. So I'm giving you hints of things that you can ask him later if you want. Okay. And then, of course, Dr. Gomez is a recent recipient of a really important international award from the Brain Behavioral Research Foundation, which we're very proud of, and congratulations. And last but not least, he's an active member of the Early and Mid-Career Committee of the International Society for Bipolar Disorders, which is an international society that advocates a lot for better treatments for individuals with bipolar disorder. With that, I'd like to welcome Dr. Gomez to the stage.
Thank you, Dr. Fry. So it's a great pleasure for me to be here tonight and talk about depression and treatment of depression in general. We'll take the lead with the new CAN-MAT guidelines, and I'll talk a bit about it. But the idea is to give an overview of how we do manage depression. Oh, sorry. Okay. So we took the opportunity that early this year, it was released a new edition of the CAN-MAT guidelines that brings some new insights in management of depression to get and kick off this public talk. So guidelines are scientific documents that we use to guide our treatments. Usually we start with diagnosis, and they also bring a broader view about management. And guidelines are usually designed by experts in the field to a particular condition. So we have guidelines across different conditions in medicine, and in psychiatry it's not different. So there is a really important group here in Canada. It's the Canadian Network for Mood and Anxiety Treatments, the CAN-MAT group, that has been publishing guidelines and treatment guidelines for various conditions, including depression. The last edition of the CAN-MAT guidelines for depression was published in 2016, and then it went into a review process, and they just published the new edition. It's interesting because a lot of people that have worked in CAN-MAT for over 30 years, they also are brought together in the CAN-BIND group, right? And so major experts in the field of mood disorders in Canada, they always have been working together to try to get those results that they get from their studies into actual clinical recommendations. So we are well equipped, all the clinicians are more well equipped to treat and best serve our patients and their families. So the last edition was led by two senior psychiatrists, Dr. Raymond Lamb and Dr. Sidney Kennedy. And you can see here the number of people that were actually and actively involved in developing these guidelines, including patient partners. So this is one really specific thing with the CAN-MAT and the CAN-BIND group that is involving people with lived experience and their families in all steps of development of the guidelines, right? To make sure that we are hearing what are the actual final user of the guideline, right? That is the actual patient and their families. The guidelines, they kind of it's developed in the way of answering a few questions related to the patient journey. And most of those questions, we had a lot of input from a group of patient partners. So the guideline, when you read the guideline, you see that all those 8 questions are answered. And this helps the readability so the clinicians are more, it's easily accessed for the clinicians to which topic they want to learn about. So we cover things like what are the important issues for assessment and diagnosis, what are the principles for depression management, how are treatments selected, what is the role of digital interventions, how the treatment is monitored, what to do when a patient is better, what to do when a patient is not better, and when other treatments should be used. So again, we're bringing information from all these different steps to healthcare providers, including mental health clinicians. So to start, we know that a comprehensive assessment is the most important and the first step in the clinical management of depression. Depression is associated with different types of symptoms and manifestations, including emotional, cognitive, and somatic symptoms. So from an emotion perspective, people would deal with low mood, lack of interest, changes in the way that they perceive themselves and the world, with a lot of negative bias. At the same time, they might have a lot of guilt, thoughts of like self-reproach and and lower self-esteem, and together with sometimes a lot of somatic symptoms and behavioral manifestations, such as changes in their appetite, changes in their biological rhythms, changes in sleep, and we have a great talk about this in a moment, and also changes in their cognition. So they might have a hard time concentrating, thinking straight, and making sound decisions. So the clinical manifestations of depression, they vary a lot. Different patients may experience in different ways, so it's important to explore all these dimensions. When we are assessing patients with depression, we also need to understand what are things related to their vulnerability and also resilience factors, so we can better plan the treatment. Understand if there's a history of trauma, even childhood trauma or trauma across the lifespan. And we usually try to gather information from different sources, such as medical charts, request information from like the family doctor, but also family, loved ones, so we can get a better understanding. Sometimes the person that is experiencing depression, they have a bias in what's going on, and they don't have the full understanding of what might be some triggering factors that might be protective, and also factors that might be worsening the course of their condition. So if we can get a broader range of information, it's usually much better. And also we need to take into account things related to cultural, ethnic factors. Different cultures, they deal differently with depression and mental health issues. So we always need to understand exactly how that suffering is seen by the patient and their family. So it's an iterative process that we use. We collect information, we try to formulate a diagnosis, and then we try to, within the appointment, to start working on how we can better manage those symptoms. we need to provide a lot of information to the patient and their families about what's depression, what are the type of treatments that are available in order to establish a good therapeutic alliance and construct and develop together with the patient a management plan that will be based on evidence-based interventions or interventions that we know that do work, and there will be a continuous need to assess if those interventions that we are implementing, if they're actually working for that specific patient. And if they're not, we need to conduct another thorough assessment, maybe have more information and so on. So sometimes this first round is successful, we are able to get information, the treatment works, but sometimes it takes several rounds of this assessment and trials of different treatments to make sure that the patient is improving. What are then the principles? So the treatment goals depends on each patient, right? So each person has eventually different goals, but the overall objectives of treatment of major depressive disorder is first, to achieve symptomatic remission, or the symptoms should be alleviated, right? And if we are able to completely clear all the symptoms, it's much better. In order to recover full function. So the final goal is to make sure that that person is back to how they were before. They were depressed, and they might be able to function properly in your community. This usually would come with restoration of their quality of life. And here sometimes we have a challenge, because sometimes the treatment might bring some side effects, for example, that might decrease their quality of life. So having a balance of controlling the symptoms, restoring function, but also maintaining quality of life, it's something that patients and clinicians need to work together to achieve. The second goal, once you are better, is to prevent recurrence or relapse or new onset of depressive symptoms, to make sure that the patient is stable, right? Overall, we also try to make sure that we have a treatment that it's safe, that it's not causing major side effects or a risk to the patient, and that overall patients would accept and tolerate them well, right? So this is something that must always be in mind when we are planning the treatment. We work in a process that is called shared decision-making, when we try to work together with patients and families to make a decision about the treatments, right? So we need to always explore and explain the types of different treatments. I'll talk about that, medication, psychotherapy, other interventions that are available. We need to provide information about how treatments work, right? So what's an antidepressant, what it's not an antidepressant, what are the effects that you can expect from an antidepressant or a psychotherapy, for example, that eventually the treatment will help with some of the symptoms. Other symptoms might not be related, for example, from the depression, might be related to something else, another condition that the person has, and maybe the antidepressant won't help. So it's not like you take that specific treatment and they will solve all the problems. We know that there are a lot of social determinants of health as well that sometimes the treatment may not address. So we need to make sure that patients are aware of the limits, but also what would be the potential benefits of the treatment. Discuss how our healthcare system works. So, for example, we know that most of patients with depression will be treated by primary care providers, family doctors, nurse practitioners, and they can be well equipped in how to treat it, but sometimes they do need recommendations, or the treatment is a bit more challenging, and that's why we have the psychiatrists that provide consultations, and eventually you might need more intensive treatment, such as being part of a group and treatment in a group setting, eventually need inpatient treatment in some specific situations. So we need a whole continuum of care. And also always provide preferred treatments, right? So every time we have the opportunity to discuss different treatments, we need to listen to the patients about what are their preferred treatments. Some patients, they don't like medication, and there might be some options that might be suitable for them. Some patients, they don't like psychotherapy, so we may try some different approaches that will not be just the medication, but maybe it's not a formal treatment program. So it's important, so this will increase the compliance, or that the patient will adhere to the treatment, and it will likely be much more successful. in that regard, we have the Choice D guideline, that it's a document that was developed by the CAN-BIND and CAN-MET groups to help patients and families to pick the treatments, right? We are working on updating this document because it was done based on the previous edition, but so soon it will be published. And some tips you can get from this document, for example, and if you can search online for Choice D PDF, and you will find it. It will be quite easy. And it helps with practical information on what you should, how you should prepare yourself to an appointment, for example. What are the usual questions that you should make to the psychiatrist or to the family doctor about your depression treatment? And it also brings some information about what are the different interventions and some basics. So you have some knowledge even before you go to your appointment or after you are already treating. So this is a really helpful resource. So we had an assessment. We decided that we'll need some treatment. What are the usual steps of the treatment? So the recent guidelines, they have acknowledged the relevance of the lifestyle modifications that we must be. And now it's acknowledged that every patient that is struggling with depression should be advised on lifestyle modifications. And this, although it's kind of sounds obvious, right? And it hasn't been so far, right? So it was more like, okay, you're depressed, you need to take a pill or you need to do some psychotherapy. And we know that if we adjust a lot of issues related to the lifestyle, you can have a lot of benefit. And you may booster the treatment, the more traditional treatments, with these lifestyle interventions. And they're basically of 4 dimensions. So increase in exercise and physical activity. If you're able to change into a more healthy diet, some people, they already have healthy diets, but some, they use a lot of highly processed foods, sugary drinks, sugary foods, and we know that these are associated with worse outcomes in depression. We know that smoking also has a negative effect, and also cessation of other substances such as alcohol and cannabis, and also work on sleep hygiene, that we'll have another talk about this as well, but the importance of regulating sleep patterns also in the treatment of depression. So every patient needs to have information about all these lifestyle interventions in the course of their treatment. And this is something that the guidelines are highlighting right now. When you get into psychological treatments, the guidelines, they do a really important work in rating the type of studies that we have and classifying the different interventions into first, second, and third line, and eventually in a non-recommended intervention. For depression, we have 3 specific types of therapy. They have the highest ranking and the best quality of data to support their use. Number 1, it's usually cognitive behavioral therapy, CBT. That is a type of talk therapy that works into changing cognitive patterns related to depressive thinking and also change the behavior. We have interpersonal therapy, that it's another type of therapy that works on different types of topics that might trigger depressive episodes. And also behavioral activation, that it's a more, let's say, hands-on treatment that usually tries to change the routine of that person that is depressed to improve their mood. Interpersonal therapy is usually used as an individual treatment one-to-one, and CBT and behavioral activation are usually group-based. And it's interesting because some studies show that the group setting might be better than the individual therapy. And from a healthcare system perspective, we can serve much more people with a group approach. So here at St. Joe's, we usually offer groups for both CBT and behavioral activation. There are a few other treatments that are also have some evidence for the treatment of depression, but those 3 are the gold standards, and they are available here at our program. Regarding the medications, you can see here there are dozens of different antidepressants that might be used. So this is already a challenge, right? How do we pick one of these specific treatments? Which one should we use? Should we use one first, the other one last? So the literature, it shows that most antidepressants work kind of in the same way and with the same efficacy. there might be a few antidepressants that might be a bit more effective than others. But usually we pick first based on this balance of effectiveness, they really improve symptoms, and tolerability. They are more well tolerated, right? And those are usually classified as first-line treatments and are usually the most common antidepressants we use. These specific guidelines, they also brought this idea of we can also show in a graphic way what are potential problems related to the antidepressants and common side effects. So this might bring another help for clinicians and eventually even patients if they're looking into this type of figures about, since they are almost every antidepressant is similar or they are effective in the same way, I might pick one that, for example, we find I have a lot of insomnia, I'm more agitated or anxious, maybe an antidepressant that is a bit more sedated. And I might find that, oh, it's sedative, I don't want that. But I might want that specific side effect, or they might help when I'm treating someone with agitation, for example. Or some that it's more activating might help someone that it's a bit more with low energy and low motivation. So the side effects, sometimes I use in a greater good. What the CAN-BIND group is doing that it's really important is to investigate ways of facilitating this treatment choice, right? So we are running a number of different studies that are looking into patient variables, blood markers or blood tests, EEG, that might help us predict some of these responses, right? And the next step might be in a comprehensive assessment. Apart from having the clinical interview, we might add some extra information that might help. Okay, someone with this clinical profile, these markers, they may respond better, for example, to this specific antidepressant, or eventually to a combination of antidepressants upfront. So this is one of the things that we are looking into, and we have studies that are enrolling at this time. So you might know someone that might be interested in participating in these studies, and it will be important to let them know. And what should be done when a patient is well? So if someone responded to the treatment with medication, with psychotherapy, we usually offer what we call booster sessions, or people may go back and do some extra sessions, for example, monthly, to make sure that they review their skills and their strategies. We usually adjust the medication. Sometimes we reduce a bit the dose. If we needed to use more than one medication, we can remove some medications, and we try to keep the medications usually for a few, after the patient is well, usually at least 1 year, but depending on the case, we might need to use it for longer periods of time. We try to make sure that those lifestyle interventions are sustained and are continue to be used by the patients. And one really important resource that we've been using more and more, and we also will be talking about this today, is about peer support. That it's engage patients that are living with depression in groups that they will have support from people that would have the same type of experiences. So we'll have also a talk about this tonight. And when the treatment it's not working, what do? We usually have a few strategies. First, to make sure that the patient is taking the medication. If they're not taking, what's the point? What's going on? Eventually, we increase the dose. We may switch the medication to a different one, maybe with a different side effect profile, or that we find that might be more useful for that specific patient. And there are a few other strategies that we call augmentation, on when we add another medication. That can be another antidepressant, or eventually medications like lithium, antipsychotics, stimulants that might help with some specific symptoms that are still present. So we usually try to work around optimizing the dose, switching agents, and adding other medications to make sure that we are getting into that goal of alleviating the symptoms and getting into remission. If we're able to get that, the chances of relapse are much lower. So that's one of our main goals. And lastly, if this approach is not working, we always have the opportunity to try some other treatments that do not involve medication or psychotherapy, including electroconvulsive therapy, that is the induction of seizures. in a controlled environment. So it's a bit more of an invasive treatment, but it's highly effective. So in more persistent and severe cases, this might be a life-saving option, for example, in life-threatening situations. And also we have RTMS, that it's a bit different, it's a bit less invasive, doesn't involve seizures, but it also involves the magnetic pulses in the brain to modulate the brain activity and improve depression. That's it. I know I maybe a few minutes than I should, but it is a lot of things to cover. Thank you.
Now, yes. So, okay.
All right.
For them.
All right. Hello? 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 Is it working? Yeah? Yeah? Okay, good. So, questions. So, let's ask Dr. Gomez anything about this or anything else that you'd like to ask. Any questions from the audience?
Maybe we can have the microphone.
So, you have 3 people. Yeah. So, go ahead.
As well as your views are on psilocybin as a touch funding.
Great question. So I'll just repeat the question. It's about psilocybin or magic mushrooms, right? Psychedelics.
This mushroom scary.
Okay, psychedelics. That's psilocybin. Yeah.
Or think that.
So psilocybin is a psychoactive agent that has been used for many decades in treatment of mental health conditions and also in exploration of the mind, right? There's been a revival of psychedelics more recently and a lot of exciting research related to the use of psychedelics. We have some good preliminary results, especially in people with treatment-resistant depression. And in some cases, we just published a study with 4 patients with bipolar II depression as well. So we have a lot of really exciting research on psychedelics and psilocybin. We also have MDMA for PTSD. So there are a number of studies. I do see them with a lot of hope, and I think there will be specific conditions and situations that might benefit a lot from psilocybin. We need to also be mindful that there might be problems related to psilocybin, related to side effects, related to experiencing more persistent symptoms. But overall, it seems like a really promising and interesting treatment option that might be available in the near future.
Thank you. There was sudden. Yeah, please.
First of all, I want to say thank you because you have this really help people with depression so badly. And a problem, and eventually, there's so many keeps getting young people, and I'm a daughter also experiencing depression. But then I myself experienced it, and then I went to the hospital. It took a month or 2 that's help. Is there anything when people get hospitalized, they pretty well was find mental state assessment and things took a month. Is there any way to shorten the span need to get that help for the patient? Like I'm sure I'm not the only one. I asked the staff, the session that was to work in that time. They said because there's so many patients on your right where to see the doctor or psychiatrist for diabetes, like it's really helpful if people decide to shorten the span because in my there are so many things can happen. I think it worsened the condition of the patient. Yes, but is the government doing to help this?
But
Thank you. So the question here is about the long waiting time that it takes for people who are suffering to actually get the help that they need.
Yeah, so this is a major issue, right? And a few things that we've been working and trying to help with that is to make sure that first, the first point of contact, that is usually the family doctors and the nurse practitioners, they are well equipped to deal with at least the first treatment of depression, right? So we acknowledge that we don't have enough psychiatrists to be the first point of contact, to be the psychiatrist, unfortunately, right? So we need to make sure that who's seeing the patients most of the time, they are aware, able to diagnose, and is at least start the treatment and manage cases that are more stable, right? The other thing we've been working hard is, again, to recruit psychiatrists to make sure that we're able to retain psychiatrists in our communities. So when we do need to have a consultation with a specialist, they are available. Another thing that this is kind of sometimes controversial, because if we at the same time have specialist clinics and people stay at the specialist clinics for a long time, we have less capacity to get new people on board, right? So what we've been trying to do is, first, in cases that we might be able to provide recommendations to the family doctor, recommend some maybe changes in their treatment, and the family doctor is able to actually implement the changes. That's what we do, right? So we make a consultation model. We work together with the family doctors to make sure that they are able to treat those cases. Cases that are much more complicated, we eventually provide some short-term follow-up where we follow them for a few sessions to be able to stabilize the case. But we do need to get the patients back to the community. Otherwise, we won't have capacity to get new people on board. And this can be frustrating for patients and families, right? Because they would expect that after waiting sometimes a few months to see a psychiatrist, they would just see them once, right? But this is the model that works in all specialties. You usually don't see a cardiologist and an endocrinologist and a neurologist and you keep seeing them. Usually they make a consult and then you get back. So this is another thing that we've been trying to do. So more complex cases that eventually were hospitalized, they may be followed for a short term, but most patients we've been trying to work together with the family doctors so we can also build capacity with the family doctors so they can better serve their patients as well. But we do recognize that this is really a complicated problem. Another thing is making sure we are having access to psychotherapy in the community, right? So another barrier was they're diagnosed. Sometimes they're using medication, but they need psychotherapy, and they would need to be referred to the hospital, for example. But now we have a really good programs, and I believe maybe Danielle may talk about that as well, in the community to improve the accessibility of these types of treatments.
And one thing that, if I can add, that we are trying to advocate for is more funding for clinical fellows and trainees, because these are people that they are already specialists, but they need to further the training, let's say, mood disorders, in complex cases. So we bring those high-level trainees to our program, and we're able to see more people, decrease the length of time for people that are on the wait list to be seen. And when we do that, the other good thing about clinical fellowships is that once they finish their training, we hope to retain them here, in the community and increase the capacity of our training for specialists that can deal with our complex tools and so on. So training is also a big part, I believe, what, we need to advocate for.
Great, so let's do it all the once. I wanted to ask you what the kind of things, let's say,
So ketamine treatments, right? We mentioned psilocybin and ketamine. We try to focus on the treatments that we have available here at St. Joe's, right? But there are other treatments that are available elsewhere. So ketamine, it's an anesthetic agent that can be used in doses that are lower than we use for anesthesia as an antidepressant. It's used as an IV infusion that are used a couple of times a week for a few weeks. And it has been shown to have antidepressant efficacy, right? Because it's a treatment that it's not approved by Health Canada, can be used everywhere. And for example, OHIP doesn't cover. So we're not able to implement this specific treatment here, although it's an effective treatment. There's been a development that is ketamine, that it's a specific substance similar to ketamine that was developed in a nasal spray. Right? So it's supposed to have similar efficacy than ketamine. It's not, again, administered as an infusion, it's a nasal spray. It's really a really expensive treatment, but some insurers, they do pay for this treatment. So especially for people with treatment-resistant depression, we usually ask and see if that specific insurer, if they would pay for that treatment, and eventually it's available and we can use. So it's a treatment with also proven results that might be used, but unfortunately there is a barrier of accessibility because the IV ketamine you need to pay out of pocket for sessions, and the IV esketamine is not covered by a lot of insurers plans.
We'll take one more question, and then Dr. Ramos will be back at the end for more questions.
You're mixing there, you're referring to lifestyle treatments, exercise, the sleep, how much eating. I recently I see a lot of research points on the link between mental health and metabolic health and use the ketogenic diet as a treatment for mental health.
That's a great question. So that's a great question. So when I was working, about ketogenic diet, so specific diets, right? So just first brief comment. We know that the quality of diet is related to incidence and course of depression. So healthy diets in general, for example, we have less highly processed foods, sugary drinks, they are less associated with depressive symptoms across the lifespan, from children to older adults. So changing the quality of the diet is an important first step. Some people, they may benefit from a more radical change in their diet that might include, for example, the ketogenic diet. The main thing is we still don't have high quality randomized clinical trials. There are the trials, the studies that we need to prove that a treatment is highly effective. So we have, for example, almost 100 years of experience in treatment of epilepsy with ketogenic diet. So it is a treatment that changes the brain physiology, so it might be helpful. Some of the treatments we use for depression, bipolar, are anticonvulsants, medications for seizure. They're used in epilepsy, so there's a lot of common points there. So because the ketogenic diet changes the way the brain uses energy, right, from glucose to ketone bodies, there's some preliminary evidence that it might help alleviate depression, right? There are currently a few studies running. I was part of one of these studies when I was working at Queen's University in Kingston. And if you look online for ketogenic diet for depression study, you will find. There is another website from Metabolic Psychiatry, Metabolic Mind, that you can also learn more about it. Again, as with psilocybin, we need just to be aware that it's kind of a high around it too. So we just need to make sure that we are not jumping into more, let's say, experimental treatments before. Some treatments that are effective were tried, but it's another area of great expectations, and we are really excited with the field of nutritional psychiatry and metabolic psychiatry. Thank you.
Excellent, thank you. And thank you all for your questions as well. It's really nice to see the engagement. So I will then invite our next speaker of the day. It's my great pleasure to call here Ada Nexa. And I should have gotten her bio first, right? So, one question, folks. It's right here. So, Dr. Nexa is a clinical coordinator in the Department of Psychiatry, Behavioral Neuroscience here at McMaster and also at the Mood Disorders Clinic here at St. Joe's. Her research focuses on mood disorders through the lens of what is called chronobiology. So, the biology of the clock, our daily 24-hour cycle, daily rhythms, the sleep and the wake cycle. So we have a biological clock in our brain. You're going to hear a little bit more about that with Dr. Nexa. So this is her focus of research. She has extensive experience using, some of those smart watches to acquire data on people rhythms, 24-hour rhythms, but also people's sleep. That is done like passively. So instead of sending someone to a sleep lab, we send them home with the device, and then we understand their sleep pattern in their own home, with their own bed, with their own environment, own children screaming, and sometimes they're, the lights sometimes on, and all that. Supported by the MITEX Global League grant, she spent 4 months in Brazil in a chronobiology lab there, getting some further training during her PhD. And her current work now involves psychometric analysis of a a novel metrics, a novel clinical instrument to understand the circadian rhythms of this depression symptoms, with a growing focus also on women's mental health and depression. So thank you, Dr. Nexus.
Okay, everybody can hear me well? Right. Hello, everybody. I'm Dr. Nexa. It's my pleasure to be presenting. No? Hello? It's my pleasure to be presenting to you today about circadian rhythms and sleep and how they might impact your mental and physical health. First, I want to talk about what circadian rhythms even are. I want to break down this word into two: circa, meaning around, and diem, meaning day. And together, this forms the word meaning around or approximately 1 day or 24 hours. And the most studied aspect of circadian rhythms is the sleep and wake cycle, as Dr. Fry mentioned, and it's largely determined by this hormone called melatonin, and this is also known as the sleep hormone. So when melatonin is produced, we feel sleepier. When it's not, we feel more awake. And it's largely controlled by this tiny region in the brain called the suprachiasmatic nucleus, or the SCN. I'll be referring to it as the SCN from now on because it's a mouthful. But essentially what happens is when it's daytime outside, the SCN sends signals to the regions that produce melatonin to stop its production. And when it's dark outside, it encourages the production of melatonin further so that it increases sleep. And the SCN projects to multiple brain areas that are involved in the generation of other types of hormones like cortisol, which many of you may be familiar with, known as the stress hormone. Kind of has an opposite rhythm to melatonin where it's highest in the morning. It encourages us to be more awake and alert. So these two are some of the most well-known hormones, but the SCN projects to numerous other brain areas, including those that are directly related to mood disorders. And not only does it project to other brain areas, but it projects all over the body. Our body, all of our organs have little clocks in them, clock genes we call them. And they essentially have their own 24-hour rhythms that are organized by the SCN, but they all have their capacity to generate their own rhythms accordingly. So this means that not only light and sleep has a capacity to affect the circadian rhythms, but other types of behaviors like the timing of your feeding or eating, the timing that you exercise, or the body temperature, and all of these lifestyle factors then enter the body either through the central clock or peripherally through other types of organs to create the circadian system as a whole. And then this leads to different types of behaviors or symptoms that we see, such as the timing of your highest and lowest body temperature, or the timing that your melatonin production starts and stops, that dictates how sleepy you are or how awake you are, and all other types of behaviors that you might not think are regulated by the circadian system, but indeed they are, like your coordination or your alertness or your best muscle strength, for example. So you can see that the circadian system is very highly integrated in the whole body. And one very interesting concept of circadian biology is something called chronotype. I don't know how many of you have heard about the concept of morning larks and evening owls, but it talks about the tendency of some people to be more morning inclined, some people are more evening inclined. Most of the community falls in kind of this in-between third bird part that we see here. And age is a very important aspect of chronotype. We see that children specifically are more morning individuals, and then as they enter adolescence, they turn into grumpy evening people. And some of these individuals stay this way into young adulthood and later into adulthood, or they might revert back into morningness or in this in-between space that we call third birds. And then as we see in older age, individuals tend to go back into the morning chronotype. So what can disrupt our circadian rhythms, and what does this mean regarding our health? First and foremost, the circadian system thrives on routine. So having a stable routine of sleeping, of exercise, of eating are all important factors to maintain your circadian rhythms.
Wow.
Yes. Oh gosh, can you hear me? And so maintaining these circadian rhythms is very important for your health. So when there are mismatches between these rhythms, what happens is that rhythms that are generated in your body, for example, the metabolism when it comes to eating, or your sleep, your melatonin rhythms when it comes to sleeping, become mismatched. And then this can lead to several health issues, whether they're physical health or mental health. And we see this a lot in individuals with depression, where some of the main criteria are something like disturbed sleep or appetite changes, like increases in appetite, decreases in appetite. We also see things like lower activity in individuals with depression, or lack of focus and low mood, of course. All of these things come together because, after all, our body is an integrated system. So one type of behavior can influence another, it can influence another, and so forth. So irregular schedules can really severely disrupt your circadian system. And we see this very clearly in individuals who work shifts. So I'm talking about those types of people who work a few days during the day and then a few during the night. They have a severely disrupted sleep schedule. And they're actually one of the most studied groups in circadian biology, because they have such a drastic change to their sleep that affects their mental health so much. And they're actually some of the most predisposed individuals to depression. They have about 40% greater chance of developing depression than individuals who don't work shifts. And if you're not one of these people, luckily, you might experience these types of effects in something called jet lag. If you traveled across a few different time zones, you might notice the effects in your body of feeling more lethargic, more tired, or lack of focus, or you might be feeling more grumpy and irritable. Your sleep might suffer. You might even have digestive issues because your system has been forwarded or gone back so many hours in a drastic way. And one very important aspect of circadian rhythms, as I mentioned in my previous slide, is your light exposure, specifically outdoor light exposure. It's thousands of times more powerful than indoor light exposure, and that's not an exaggeration. Sunlight is a very powerful trainer of your circadian system. So spending time outdoors is really great, especially in the morning, to tell your body that you are awake. Unfortunately, nowadays, a lot of our work involves being inside, as you can see, with more artificial lighting, sometimes no windows. So that's unfortunately pretty bad for your circadian system. So as much as you can get light outside, it's really important. And I said especially morning light because that contains a lot of blue light. If you can imagine the light spectrum, morning light contains more blue light, and this is has a very strong effect on your circadian system as a whole. Which brings me to my other point. On the flip side, having blue light exposure in the evening is very detrimental to your circadian system. So we nowadays have a lot of access to this, either through artificial lighting or if we have devices, which I'm sure many of us have. Exposing yourself to this late at night has a lot of potential to shift that melatonin curve that I spoke about earlier. So melatonin, because its production stops when when you're being exposed to light, having light exposure, especially blue light at night, has the potential to shift it forward so that you feel sleepier later. And this is a big problem for individuals who have to get up at the same time every day to go to work, because melatonin production is later. That means it stops later as well. And this then can make you feel groggy in the morning, etc., etc. And lastly, substance use. Caffeine is a very big one. I hope you guys didn't have the regular coffee there and got the decaf coffee instead. I know I did. But caffeine is a very powerful modulator of the circadian system because it's a stimulant and it helps you stay awake for longer, and it stays in your system for a very long time. And alcohol as well. I'm sure those of you who have had those nights where you've had a few drinks, you've noticed the effect that it has on your sleep. And moreover, the day after, because alcohol also stays in your system for a long time, and your circadian system is not used to any foreign type substances entering your body. So the more of these that you ingest, the more it has to work to regulate itself back to normal, essentially. So this is all to say, I'm not going to explain this big picture, don't worry, but this is all to say that the circadian system is a very integrated system. It's not just that one area in the brain that dictates our rhythms. It very much projects to other brain areas, to all of our organs, and it's very important to think of this system as a whole. So when one type of behavior gets interrupted, it can affect another, and so forth. And the link with mood disorders, specifically depression, has been very well studied, although we can't really pinpoint to something to say that this is the cause of depression if you disrupt your circadian rhythm in a certain way. But we have seen a lot of commonalities between the disruption in circadian rhythms and the symptoms that we see in depression. Like I said, a lot of depressed individuals have disrupted sleep. Some of them have a lot of insomnia, or they have too much sleep, called hypersomnia. Activity tends to be lower in individuals with depression, lack of focus as well, appetite changes too. So all of these work together to provide these manifestations that we see in depressed individuals, and then either directly through the link with centers in the brain that are mood related, or indirectly through these other systems, the circadian rhythm disruptions can affect mood in that way. And I want to leave you here with some tips to maintain a healthy circadian system. Of course, we have many medically related ways to do this, but for you guys, some lifestyle changes would be very important. First and foremost, having a consistent sleep schedule is of utmost importance. Your body has very different processes that it employs when you are awake versus when you're asleep and you're in a rest and digest type of state. So if you can help your body predict when you're about to go to sleep or when you're about to wake up, it will help you back and make the process a much smoother transition than it would be if you had irregular schedules. So if possible, try to maintain a consistent sleep schedule. If you can, try to maintain a consistent wake schedule, and that will kind of help you out. And as well, exposure to natural light, as I spoke about before, specifically natural light in the morning, and limiting blue light exposure in the evening, at least a few hours before your bedtime. And avoiding caffeinated drinks or alcohol or heavy meals before bedtime, because as your body is preparing to shut down for the night, introducing these types of substances will have it start to work again. And so it will not maintain that circadian system that it's expecting. And of course, exercising regularly, allowing the body to do what it's meant to do, to move and burn off that energy. So essentially, these tips are to help your body to help you. So I hope these recommendations will help you think about the circadian system as an integrated system in your body, so you can see how it might affect you personally, whether it's for physical health or for mental health, and from now on to see it as a source of modification for your behavior to better your health in whatever way that you can. Thank you.
All right, so I was told to have 2 questions, and then we're going to bring that back at the end.
Thank you.
Sorry, I can't hear you at all. Sorry.
I was going to say, great talk. What nice appreciate let's make this. My question was, I'm pretty scared that mixed with this a lot and should with this. So, but I was wondering if you read on geotonical weight circadian rhythm among the airlines or the pilots, for example. And I know they go to training and other things supposing patients get to that profession, but then have this impact of the school game. Are there actually long-term repercussions in coming about the thinking in terms of this body message?
Yes, that's a really good question. This question was about the circadian rhythms of airline employees, like pilots and stewardesses. Very great question. This is super tightly linked to shift work as well. As you can imagine, they also have disrupted sleep schedules, as shift workers do. But just as shift workers as well, they have a few days off. So this is what I understand when it comes to airline workers, is that they work a few days and then they have a few days to recuperate as well. I have seen a couple of studies on this. They're not the most studied group in comparison to shift workers specifically, but they do also suffer from a lot of physical and mental health issues in the same way, because not only are they working long hours in terms of being on the plane, but they also transfer time zones. So it's kind of an amalgamation of the night shift issues and the jet lag issues. So if you can imagine, their circadian system is completely disrupted, not only in terms of their own biology, but its synchronization with the outside light as well. So of course, they would also have some issues in terms of mental and physical health. Good question. Thank you.
I know it sounds a bit louder. Yeah. Thanks so much for the presentation. I know research has changed in terms of how many hours we need, like sleep a night, a sleep change throughout what I've heard as a teenager and then now, recently I'm hearing that humans need more hours of sleep
For example, what I do like found with problem, especially in terms of having determined how many hours of sleep. Yeah, that's a really good question. There are broad guidelines about how many hours of sleep an individual should get. They say 7 to 9 hours is what's recommended. From my understanding, it's more important to think about the regularity of your sleep than the amount of sleep that you receive. Of course, having 3-4 hours of sleep at night is also not great because your body, the way that sleep works is it goes through a few processes of sleep cycles called REM and non-REM cycles, and they last about an hour and a half each. And what happens throughout the night is that in the first portion of the night, you have more deep sleep and less REM. And so your body goes through more physical restorative processes. And then as the night goes on and the REM and non-REM cycles repeat, you have more REM near the end of the night or near the waking time. And this also has a lot of great implications in the way that it helps mental health. There are some studies that show changes in REM sleep in individuals with depression and schizophrenia mostly. But that's more regarding the type of quality of sleep that they get, because one thing that can happen when somebody does not get restorative sleep is that it gets interrupted. So the REM cycle gets interrupted and they're not able to finish naturally speaking. So my recommendation here would be to think more about how regular your sleep schedule is so your body can get used to how much time it has to repeat these REM and non-REM cycles, and of course get as much sleep as possible. But there is also a thing as too much sleep. As I mentioned, individuals with depression, some get too little, some get too much. So it really is an individual preference, or I guess the body's individual preference for how much sleep you should get, but definitely focusing on the regularity of sleep would be something that you can control yourself. Thank you. Thank you.
All right. So it's my pleasure to invite another wonderful colleague of mine, Dr. Danielle Rice. Dr. Rice is a clinical and health psychologist here at the Mood Disorders Clinic and is also an assistant professor at McMaster University, Department of Psychiatry and Behavioral Neuroscience. Clinically, Dr. Rice focuses on providing treatment and assessment to individuals with complex mental health conditions, including depression, and also depression that co-occurs with other conditions. Sometimes depression comes with PTSD, anxiety, and so on. Dr. Rice's research focuses on improving the accessibility and quality of mental health and addictions care within Canada. She's published like over 100 medical articles, several of which have been used to inform best practice clinical guidelines. And I first got to know her work when, I was reading one of her amazing articles in Postpartum Depression, one of the best one ever published, in my opinion. She is an advocate for improving the mental health care system and has been collaborating on provincial initiatives for mental health and addictions care, such as working with Ontario Health, as well as the Mental Health and Addiction Center of Excellence of Ontario.
Okay, I'm going to test this first. I'm pretty tall. This is quite small. Can you hear me? Can you still hear me? Okay, lovely. Oh, actually less.
Super long.
Damn, I didn't think I was that tall.
Better to use this one?
Sure. Can I try this? Testing?
It didn't. Yeah, there.
Testing? Yes? Okay, thank you so much for bearing with me.
Nothing got those.
There we go. So I'm going to be speaking about psychotherapy, sort of how to prep, what to expect when starting psychotherapy. I've put it for depression, but if it's for other conditions, I think this will hopefully translate well to other mental health conditions that may occur. I do want to mention that when I prepared this talk, I'm thinking about it as though you've decided you may be interested in psychotherapy. You've reviewed that beautiful patient guide that Dr. Gomez described from the CanVine and CanMat family guide, where they have a nice pro-con list of pros and cons of psychological therapy. So I want to go with the perspective that you thought, yeah, maybe I'm going to dip my toe in this psychological approach, and then let's see where it goes. I also just want to note I don't have any conflicts of interest, so everything that I share is just based on research and clinical experience. I'm going to aim to do a very brief overview of what psychotherapy is, when, where, and how to access it, what to expect, how to prep, and I'm sorry, I'm going to assign you a little bit of homework at the end. That's what psychologists do, but it's not too bad, I promise. So as has already been very well described, psychotherapy or psychological treatment or talk therapy, these terms can kind of be used interchangeably. This involves speaking with a mental health professional to try and identify ways you may want to change thoughts or change your relationships with thoughts, perhaps change your behavior. As is also described well, individuals will have different goals for therapy, which is completely fine. From the mental health professional perspective, often our goals for you or for a client is going to center around improving quality of life, reducing those depressive symptoms that are happening, and enhancing day-to-day functioning. Now, if someone's goal is I want to improve that relationship with my husband or my child, and depression is getting in the way, of course, bring this. That completely is under the realm of what psychological treatment can help with, but these are some of the goals that we often expect to see. This is a quote from one of my supervisors. Therapy is something you do, it's not something you get. So think of this in the sense that you go to get your hair cut, you sit back, you relax. As a side note, I was originally going to say you go to the dentist, but no one relaxes at the dentist. So I changed it while I'm here. You sit back, you relax, you get this nice haircut that make you look like Jennifer Aniston, life is good. I wish that this is what psychotherapy was, however, it's not. What it is it's a collaborative effort between an individual or a group in a group setting and a mental health professional. So it is not something that you arrive and you get. It's something that is an ongoing process that you're working towards. So I want to take a second to break down a little bit more of what's been touched on. Where and how can I access therapy? The when, again, we're going to pretend that you've thought about this, you've decided this might be something you're interested in. So where we can get therapy. I'm not going to try and find a pointer. Employee assistance programs. This is something EAP, if that's a term you've heard of before, as well as academic counseling centers. This is an option sometimes for individuals if they're working. EAP could be something that's offered through your work setting. Similarly, if you're at a university or a college, these are often their wellness centers or counseling centers on site. These different options would be freely accessible. They're typically short-term. Sometimes you can think about it as though there's a more time-sensitive problem or a concern that's happening. These may be the locations you want to try first. They're, in general, fairly low barrier, meaning you don't have to get a referral for them, and hopefully easily accessible. For example, walking down to your local, if you're a student, for example, walking down to that counseling center. This is going to change institution by institution, but in general, something you can consider. I'm going to go to the next box, provincially supported therapy services. This was just touched on, and I'm going to expand a bit. These are newer initiatives that have started in Ontario. OSP is the acronym I'm going to hopefully leave you with tonight. Ontario's Structured Psychotherapy Program. This is, again, recently developed approaches to therapy for mild to moderate depression or anxiety services. And these are nice because they're offered online or in person. They can be really flexible for individuals. Let's say you're working and you're not able to necessarily attend 2 hours of group each week. This can involve some sort of at-home work and touch points with a therapist, or if that's not doing the trick, and you can be stepped up, so to speak, to that 2-hour group, or perhaps even one-to-one therapy, again, depending on what's going to be best for the patient. So these are new. The treatments that are offered are very well studied. They're the old school evidence-based ones, but the program itself is fairly new, meaning that it's actually shorter wait. I know it was highlighted how the waits can be quite long. This is an opportunity for therapy, which actually is a much shorter wait than is common. Again, I have no financial affiliation there. That is just genuinely the service. Moving on to private psychotherapy. Private psychotherapy is sort of like if you're going to see a physiotherapist, or again, let's use a dentist. This is something that is not covered by OHIP. You may have private insurance if you're working that can cover some of this cost, but in general, private psychotherapy is fairly expensive and not as accessible if you don't have insurance coverage. So this would be a setting where you're arriving. If you have insurance coverage, that is great. If not, it does end up being fairly expensive, but it is typically can be quicker than some of these other options, although not always the case. All of those three options I've noted so far, you do not need a referral to. You get to go yourself without needing a doctor's referral. The last one I'll touch on has been also mentioned, which is your family doctor, or if you're in a family health team, or this lovely institution that we're in right now, that's going to be the hospital, which is another option for receiving psychotherapy. As noted, this would be a setting where it's going to be time limited. It's going to be focused on what research shows is helpful, and these generally will require a referral from either a doctor or some other medical professional. Those are the pictures. So that is something to consider, but your primary care doctor may have someone in the community or associated social worker or social work team that can help as a first step to providing therapy. So what to expect? So I like to tell people that right on the left-hand side there, it's really important to expect you're going to go through incredibly boring, but fairly important bureaucratic information in that first session. This is going to be things like informed consent. Do you know where and when a therapist can or has to legally share information? Are they up to date on your emergency contact information, your address, things like that? So this will be a chunk. Most people are perhaps nervous, but also excited to share what's been happening in their life. And unfortunately, we hit you with a set of bureaucratic information first. So I like to let people know that. Also, as was mentioned, almost always a first appointment or first session is going to be a pretty lengthy set of questionnaires or interview or assessment, whatever term sits best with you. Some of those questions may be paper-based or online, and many of them will be just asked orally or verbally. So you can see just some examples here, what we'll ask about. We'll ask about sleep, for example. We'll ask about diet, substance use, any medications that you're on, friendship circle, coping strategies, things like that. So we just want to start getting to know you. Then we get into that good stuff of treatment. So how to prep? In general, you don't have to prep a ton. If you just show up without any thoughts, that is completely fine. We'll put you sort of that small step ahead for yourself is if you've thought about those goals that you have. If you've thought about what would make things better. If I met you 4 months from now and things were better, what would that look like? What would be different? How would we know if therapy is quote unquote working? So that can be really helpful to think about. It doesn't have to be fully formulated, doesn't have to be written down. Just have a good sense in your mind of what could be helpful for you. The next one is thinking about expectations. So are you looking for virtual or online? Are you hoping to do a drop-in format? Because again, we can think about that with referrals, so on and so forth. I won't touch on every single one of these, but I will highlight number 3, which is if you've had treatments previously and things were or weren't helpful, having a good sense of that can be really useful for your therapist, because then we can not reinvent the wheel or go a completely different direction to not try something that hasn't worked. And I'll just also highlight number 5, which is having a little bit of a buffer between when your session is expected to end and whatever your next responsibility is. It can be very draining, answering a lot of questions. You may be sharing information you haven't shared before. It is very reasonable and I find helpful for people to have a bit of space before the next thing that they're planning to do. So sometimes people want to come from 8 a.m. to 9 a.m., which is totally fine. But if they're planning to go into a 9 a.m. meeting, that can be kind of tricky. So something to think about with scheduling if you have the ability to schedule that way. Setting yourself up for success. So as is really nicely highlighted, there's these 3 great first-line treatments: CBT, behavioral activation, and IPT. Don't worry about the acronyms so much, but what I want to share is that outside of those different approaches, there are also some core components of therapy that have been shown to be really helpful, regardless if you're getting CBT, IPT, BA, or whatever it may be. And this first one is therapeutic relationship. So what it means is that you feel comfortable to some extent sharing with the person that you're meeting with. It's challenging to do therapy on the therapist end, but also on your end if you don't feel comfortable sharing some of the information of what's been happening in your life. So you want to sort of have a good sense of, are you having some trust with this individual? Are you willing to open up? Does it seem like a good fit, quote unquote? It's something to watch out for, because that really, really has been shown to help with outcomes and how well things go. Second point here is expectations. So having a sense of what is happening. Does it look like depression? Are we going to be meeting for the next 5 weeks, 5 months, whatever it may be? And then those common goals. So sharing the goals with your therapist and maybe rejigging them a bit together to make sure they're realistic. The third point here to set up for success is cultural adaptation. So if there's anything that would be relevant for a therapist to know, hopefully they ask you about any adaptations that may be relevant. But that's something that we want to make sure is brought into the room and discussed openly. And I'm getting near the end. I think I'm probably almost over time. But one of the questions may be, what if it's not working? So maybe you're in therapy right now and you're wondering, is it working or is it not? An important aspect to consider and for you to think about and hopefully for your treatment team to think about is considering those symptoms. So those depressive symptoms that you may be reporting. Low mood, feeling fatigued, challenges sleeping, challenges with cognition, whatever that may be. It's ideal to have these tracked over time so you can see progress, hopefully, or figure out when things need to be rejigged. So this is something you can certainly do online if you want, or you can bring it to your therapist and hopefully, or where you're being treated does this anyway. We certainly do this here at St. Joe's, but you want to be able to see how things are going and have an open conversation. This says if things are perhaps needing to take a different course, perhaps need another meeting with a psychiatrist to touch up on meds or something along those lines. Here, for an example, you see a reduction in numbers. This would suggest fewer depressive symptoms. This would be kind of the good sign. Here is an example where around January, February, somewhere around there, you see a spike. This is when an individual was starting back at work after having been off of work for quite a while. This individual did, move past that spike in anxiety, return to work. You can see the anxiety reduced by the end. So these are open conversations to have, and it's not a bad thing if the symptoms go up. We just want to know what's happening, and then perhaps take a focus on anxiety in this example when the depressive symptoms were continuing to reduce. So I'm going to wrap up and just note what if it's not working. I think Dr. Gomez had a really nice slide on this as well. So I will just highlight open conversation with the therapist. That's that therapeutic relationship we hope is strong. Reflect on, are you doing that homework, that pesky homework that I mentioned in my intro? Is that being done? Are we targeting the right problem? Have things changed? Are we working on the right goal? Just sort of those reflective questions and hopefully a really open conversation about this with your team. So to give some takeaways, number one is that psychotherapy can be accessed online, accessed online or in person in many different settings in Ontario currently. I know there are sometimes a wait, but we are, in general, I think collaboratively and collectively as a province, we're doing all that we can to try and reduce that wait and make additional options that are immediately accessible or almost immediately accessible. The first session will involve a lot of questions, as mentioned. Third point here, if you can be ready to think about those goals that you may have for therapy, that can be really helpful. And that's what I would that's what I would assign for homework, so to speak, is if you're thinking about therapy, maybe come up with 1 or 2 goals, just high level, that you would be able to bring to your first appointment. And I'll stop there. Thank you so much.
Those are 2 questions.
I want to know what is the very important Dr. phrase by what's the best starting point the version mentioned?
Both farm.
Is it published? Is it a PhD?
Yeah.
Studying to the S?
Yeah. You can say both. Yeah, both.
I think it's published in BMJ. Yeah. BMJ, it's a British medical journal. It's like a peer-reviewed, and imagine like holding a paper, which is not helpful. It's a peer-reviewed article you can find online. You're going to want to type in EPBS, and then that and sign, the ampersand, BMJ, and then one more and sign, I would type in THOMBS. That's my old supervisor. He's not old in general. He's just my previous supervisor. His name is Dr. Toons. So that should find it.
Thank you. Yeah, that's a medical screening. How to screen for depression. Yeah, it's not about treatment. It's not about symptoms. It's about tools for screening. And that one was a very large study. It was beautifully done. There was somebody else over there. Yeah, over there.
Today happened.
Can you speak all that then?
First of all, thank you for the talk of the grace that you mentioned that therapies must end up happening to individuals. This thing that we have to work towards to get the most benefit out of. With that in mind, what are some best practices things with all therapy can work to understand and to this therapy? I started to enhance
Enhance what?
the effects of therapy.
The effects of it. Can you repeat the question?
Yes,
I'm pretty sure I heard it all where I mentioned that note about how therapy isn't really something that you get, it's something that you do. So the question was, how can we what should we do and how can we optimize the impact that treatment may have? Thank you. So you know what, the first thing I think, as some of it's been mentioned in different ways, is just that open line of communication with a therapist, even asking, how do you think things are going? Is my homework going well? Am I doing it? And it's not reassurance seeking, it's genuinely trying to get a sense of how is this going from their perspective. The other thing is being open to changing course. So let's say one of your goals perhaps is to exercise 5 times a week. I don't want to take that away from you. But if you're starting at 0, I may suggest we start at a range of, let's aim for 2 to 4 times a week. And you may internally think, I don't like that, I want to do 5. That's fine, you can tell me. But if you can be flexible to know, let's maybe try that range from 2 to 4 times, that can be really helpful. Sort of coming with an open mind and some flexibility. And if something doesn't work, your mental health professional should be willing to say, you know what, we tried it, and you end up doing 7 times, so let's increase that goal. We don't want to hold you back. I think those would be a few things to think about.
One follow-up comment on this is, it's common for me as a psychiatrist. Some people would say, I'm doing therapy, I'm not enjoying, I don't think it's working. And one of the things that I encourage patients to say is, talk to your therapist. That you're not enjoying, that it's not working. If it's a good therapist, they won't take it personally, like you're accusing me that the treatment is not working, nothing like that. They will just say, okay, let's work together to try and clarify what's happening, right? So it's important. That's like the advice that I give my patients, to talk to therapists.
Thank you very much. Appreciate that, therapy. All right, so it is my great pleasure to introduce the next 2 speakers of today. So Tara Richardson is a peer support provider at St. Joe's in the Patient and Family Collaborative Support Service Department, where she used her lived experience to help peers on their mental health recovery journey. Tara has worked in the peer support field since 2012, so a lot of years of experience. And is an advanced level RAC facilitator. She holds a BA in psychology, is a registered social service worker, and has received a certificate in applied positive psychology through the Flourishing Center. In 2020, Tara created the 16-week peer recovery workshops program offered for peers at St. Joe's that promotes strategies to build positive mental health and encourage discussions beyond mental illness, which has been well attended at the 3 times it's been offered, both socially and in person. Tara also was a wellness columnist for a magazine in their region for 9 years and has written various blogs and articles on mental health over the past 2 decades, published online and in various newspapers. She's a passionate advocate for recovery, for mental health illness, and living a meaningful or fulfilled life. Very beautiful. Angela Justin has been a peer support provider at St. Joe's as well for the past 6 years, so tons of experience as well, offering support to individuals in the Hampton area. Angela has served as talking about mental illness, the TED speaker for over 10 years, sharing her mental health journey with the community and regularly speaks to the Hampton Police, providing valuable insights into mental health. Angela has also participated in crisis intervention training for 8 years and works part-time as an assistant research coordinator on youth with the first episode of psychosis and cannabis use disorders. She's contributed to several educational projects in collaboration with McMaster University Law College during working in PhD, psychiatry, physician assistant service, and in her free time, Angela enjoys spending time with family and friends and watching TikTok videos. So welcome, very nice. Welcome, Tara and John.
Hi, group, yes. So thanks to everyone for inviting us to speak tonight. So I just want to introduce peer support and what it is. So we all have lived experience with mental illness and or addictions, and we're hired by the hospital to help peers on the recovery journey, whatever that may look like for them. So peer support provides support for personal recovery goal setting and activities
it's going to be unique to everyone. We offer transitional support from inpatient to community support, so we will follow people from inpatient to outpatient or refer them to community resources. We offer system navigation for individuals and families. We have problem solving and support with treatment teams if necessary. We also talk a lot about self-advocacy with our peers. We have attendance at treatment and our family meetings. We have debriefing with peer after seclusion or restraint experience. We recognize that those can be extremely stressful for our peers, and we want to try and process that with them. And then we will accompany our peers to support transition and success. So if they're a little nervous going to a program for the first time, we might go with them and offer support. We also offer peer-led groups and one-to-one interactions, probably. According to Peer Support Canada, there's these peer support core values. So there's hope and recovery, empathetic and equal relationships, self-determination, dignity, respect, and social inclusion, integrity, authenticity, and trust, health and wellness, lifelong learning, and personal growth. Personally, I've experienced many episodes of depression and hospitalizations, and as a peer support provider, I hold the hope for my peers, and I can use my lived experience to help them and hold the hope for them until they're ready and able to have that for themselves. So this is a very detailed slide, but peer support has been around for a long time, since the 18th century, not both formalized and informalized. Excuse me. And it's recognized in various healthcare, substance use, diabetes, dementia care, etc. It was declared an evidence-based practice in 2007 in the U.S. And WRAP, which we mentioned, which stands for Wellness Recovery Action Plan, was developed in 1997. And in 2010, it became an evidence-based peer-led group program, which is actually like the only evidence, not the only, but the main evidence-based group practice in the U.S. and Canada. At St. Joe's, we use a valid and reliable peer support integrity scale, and it shows that peer support significantly increased individual sense of empowerment, hope, autonomy, feelings of validation and meaning in their life, and decreased feelings of hopelessness, stigma, lack of control, and loneliness. So we've had a lot of positive outcomes from peer support. So reduced hospitalization, reduced length of stay in hospitalization, which is also cost effective for the hospital because hospital bed versus community visit. And then also we have increased use and knowledge of crisis supports, which also translates to reduced hospitalization, increase in sustained engagement with clinical care, so we can try and connect our peers with their clinical team and make sure that they're connecting. Increased quality of life, increased sense of personal empowerment, increased hope, reduced self-stigma, decreased substance use, can increase use of safer self-management and coping skills, and increase self-efficacy. And I'm going to pass it off to Angela.
So throughout St. Joe's, peer support is scattered through various teams and clinics. So the Patient and Family Collaborative Support Services Department, which is where Tara and I worked with other, I'll get into details of how many people and who works there. But so there's our department. We service inpatient and outpatient people in the community, people with lived experience with mental health and addiction, and their families. So when we say peer support, we don't just mean people with the lived experience, we also mean their families and their loved ones that are part of their lives as well. So we travel around, we provide service in Brant, and Niagara Falls, Haldimand, Norfolk, and all of Hamilton. We also have peer providers who work with younger people. So there's Cleghorn program for early intervention of psychosis. There's the Youth Wellness Center, Bridge to Recovery, Community Psychiatry, just to name a few. Which button? Okay. So here's more specific information about our department. So there's 10 peer support providers currently. There are a mix of full-time and part-time. We have 2 family peer support providers. One of them is a full-time employee. We have a resource center that is stocked with up-to-date and sought-after information, and it's looked after by a part-time provider. We have an administrator who we couldn't do half the things that we do without, and we also have our manager. And then throughout our program, we also have volunteers supporting the 2 resource centers, the inpatient side and also the side that the community can access. So who do we serve? We've explained to you that both of us are people with lived experiences with mental illness. So service people like us and our families, and people who are not with dedicated services, not necessarily attached to St. Joe's or any of the affiliates that provide care. So we, like I said earlier, we do provide support to people who live in Niagara, Haldimand, and Burlington, as well as Hamilton, all of Hamilton. Some of our services that we offer one-to-one peer support. One-to-one peer support. We offer groups as well. So we have different kinds of groups. We have a drop-in group that people can come to. It's usually sort of like an AA group in a sense that we come with some sort of plan to talk about what's going on in our lives and how we can, as a group, support one another. It's a very family-oriented type of experience. People come regularly. It tends to be the same number of people. And so there's a really great camaraderie and improvement in people's moods when they're seeing the same people and they're part of a group. Tara was saying that we offer WRAP, the Wellness Recovery Action Plan. That's something that we run numerous times a year. It's also very well received. It's to prevent or to prepare for somebody if, when it comes to mental health, things are not cured, they're maintained. And so there's ups and downs, and so there's times where things like a WRAP, like an action plan, really comes in handy. We also offer Skills for Safer Living, which is a suicide prevention and intervention training. It's for people who have made attempts and have survived them, and also people who live with ongoing ideation. We have some social networking groups, which is also really important. We have found in our years of supplying peer support that there's a lot of isolation amongst people who experience various either mental illnesses or addictions or both. And so these social networking groups give people the opportunity to get together and to not necessarily like some of the other groups talk about things that are bothering them, but just to hang out, to shoot the what do they say? To shoot the breeze, and that was actually requested by the participants of our program. We had the other ones that had been long-standing, but this was actually requested, and I don't know where I came up with the name, but I decided to name it Peer to There. It's our social networking group. Our family support workers, they have a one-to-one program as well as a open family group support group. We have a mental health and wellness resource center. As I was saying, we are in tune with all the top information and knowledge sharing that we can find, that we hear of, that we know of. We have a family resource center that also is ever expanding with information. And then, as Tara had mentioned, one of the other services that is, well, it's debriefing with peers after a seclusion or restraint. It's us coming to them to get their point of view, to highlight that this is meant for them as a way to feel supported. It's not to get into trouble or to feel like you're telling on, staff. It's for us to make sure that they feel and that they know that they're heard and that they are okay. As we know that it can be a very traumatizing experience. We also have various councils for the Mental Health and Addictions Program with people who are people with lived experiences and their loved ones. So connecting with peer support is really easy. You can do a self-referral. You can call the hospital's phone number and dial the extension, as you can see, 39559. You'll speak to our wonderful Alejandra, who works at the front. She's very helpful and very informative, and she'll help you get to the right place. Same with family peer support. You see the extension is there. You don't have to have a doctor. You don't have to have a social worker or an OT. You can call yourself. You can do a referral, usually right over the phone with one of us. We'll call you. We'll work through it. And sometimes we have a little bit of a wait list, but we work very hard at making sure that wait list does not get bigger. So we want just reading here. Okay, I think that's good for that slide. And just to note that family peer support is very, even though we offer both, and our department focuses on both perspectives, they don't intermingle. So if I work with your son, our conversation never gets passed on to the conversation that the mother or your partner or your husband or your wife would speak to with the family peer support providers. So this is a quote chosen by Tara, and I seconded it. I thought it was a really good one. So it starts with, each person has skills, gifts, and talents they can use to better their own life. Peer support focuses on what's strong, not what's wrong in another's life. Peer supporters share their own experience to encourage people to see the silver lining or the positive things they have gained through adversity. So thank you.